for my pediatric patients, working with Sylvia was helpful for my technique for certain aspects of the work I did with pediatric patients. I think the other thing that was probably most meaningful from that experience was simply the notion of how one prepares families and works holistically with families and the kids before you actually intervene and do procedures. And I've tried to take that into my practice. I thought I had that down pretty well before I left, but once I saw the model that they worked in, I realized it actually had a long way to go. And I've really tried to make that the way in which, taking a little bit of extra time, being a little bit more engaged in some of those relationship-based elements of care really makes a huge difference. I think you saw from the picture of the kid going to sleep. I mean, he's putting the mask on his face. That's a very, very different child who has a very, very different course than a kid that you're putting the mask on and trying to, or either that or giving them medication to make them sleepy before they go in and those sorts of things. So I think that that's probably made a difference.
Great, thank you. So Bill, I think this question's apropos given our discussion earlier this afternoon. But what tactics have you used to ensure compassionate service in the face of the bureaucracy and the politics of your organization? No.
Well, I have to say that my experience in India had great influence on wanting to bring back what we saw and experienced in India to help humanize the biotechnical kind of contemporary medicine experience. And I think what has become the Institute for Health and Healing was an effort to model the kinds of holistic sort of caring that was witnessed in India. Facetiously, I kidded Dr. Venkataswamy that I needed lab space in India to begin the work that would allow the development of a vaccination so that we could take the culture that he had created at Aravind and spread it all over the world. Because it's very difficult to transplant culture. And I don't mean culture as in the Indian culture versus some other culture, but the culture of compassion and mercy and dignity and respect that was brought forward by the staff to every patient who walked through the door. So in trying to do that, one of our taglines at the Institute for Health and Healing is every encounter needs to be a healing experience among the staff, to staff with patients, to staff with colleagues. And I think that's what we've seen in India and that Aravind models, and what was a goal to bring back to the experience in the U.S.
Thank you.
Abe, can I make a brief
Of course,
comment
please.
On that? Because Dr. Stewart will not say this, so I will now embarrass him publicly because I think it's worth doing. You're all here as part of the Institute for Health and Healing Mini Medical School series. We kind of take these things for granted. The IHH now is 12 years old, something. What is it?
Well, even more than that.
15?
Yeah. Well, we've got our first go-ahead in February of 1990. A letter was written by the CEO to bring together the first advisory council for what became the Institute for Health and Healing.
Okay, so there you go. And I was actually on the advisory council.
Yes, you were.
And what I'm going to say is that because of your leadership, I mean, the culture and what we had then was a very, very different model. There was not even a notion that something like this could or even should exist in our sort of Western health care delivery system that we had going, at least in our hospitals. And I think that there's been just such a different change. The fact that people would even think about it, that people would fundraise for it now, that people expect that we would have events like this, that people would expect that you would come in and have healing harp therapies and things, that we'd be arguing over how can we get this in the East Bay, we want this, we want that. I think that's been a huge change. Not that we're there yet, but I think that it has been, really your efforts have been Aravinesque in the San Francisco community, and I really appreciate that. So
Well,
I wanted to acknowledge
thank
that.
you, Steve.
Maybe as a follow-up question to that for Pavi, what, I guess in your experience, in your research, what tactics have you seen other healthcare organizations take, maybe in a less formalized process than the IHH, to really drive a different model of compassion in the care they deliver?
In what part of the world or anywhere?
Whatever part's been successful in doing it.
I think what's really interesting in Arvind's replication efforts, when it's worked now in, like I said, over 270 hospitals in very different parts of the world, and it's not a cookie cutter model. You can't just pick up what's happening in southern India and lay it down exactly in parts of Africa or in Vietnam or in Nepal even, or in San Francisco, exactly. And what's been interesting is that what really makes or breaks the success of this model isn't the macro factors that people tend to think of. Oh, regulations are different, or politics, government, all of that isn't really what's made the difference. It's the internal culture, like you were saying, of the organization. And it's very simple things sometimes. Do they have a continuity in the upper management, or is there a high turnover there? Do the doctors, are they full-time employees or part-time staff? Do they have private clinics and competing interests? Are salaries linked to volume or to outcomes? And so those kinds of things, once they've identified a whole series of things that are very much in the control of the organization, and the places that Aravind has worked with that have seen the greatest success in terms of replicating the model are those that pay attention to that leadership and that work ethic, and those aspects that are actually much more within grasp.
Sure. I think much of the things that we struggle with on a day-to-day basis in transforming our own healthcare system is the alignment of incentives and culture, from the C-suite all the way down to the operating table, and making sure there's the consistency in our intentions and our approach. And maybe with that, to transition to, I'm looking at the questions, and over half of them are really around the same topic, which, of course, in today's debate is very relevant, which is how can we change the economics of healthcare in the U.S.? And so I will start with Dr. Lockhart's view of that.
Well, understanding the hour is late and the political rants are probably not what you came to hear, I will say that, I spent the 2 years I spent in England in graduate school, I actually spent studying the British National Health Service, and I'm a mathematician, so I did a bunch of nerdy things. But I think two things. One is we have to change our perspective in terms of what it means to provide health care and the value of it. I don't see it as a good or service. I see it as something that people have a right to, that everyone needs to have, just as they would have clean air. I mean, we say you can't pollute because people get hurt. We have to provide an appropriate amount of care for people. So I just think our system is structured improperly. We have for-profit insurance companies, drug companies, et cetera. We have delivery systems that are not for profit, and we need to reconcile those two in a way that, we don't get compensated for taking care of sick people, but we get, rewarded for keeping people well. And that really is a total overhaul. I in my humble opinion, that the new regulation is an attempt to get there. I think it hasn't gone nearly far enough, but I think one of the good things is maybe, if we can get past this polarization, is that it started us, at least as a nation, in a dialogue, recognizing that we're, 21st in terms of outcomes, and we're first in terms of cost, and that relationship just doesn't really work. And you saw with the Aravind example, I mean, you've got millions of people getting care that's as good or better than the care that we provide here for, millions times the cost. So I think it's a national dialogue that we have, that has to get past the polarization and require some fundamental restructuring before we can make real progress. That's my radical socialist views.
Well, let me speak to your radical socialist views also. We spend the vast majority of our so-called healthcare resources on end-stage disease, which is affecting less than 20% of the population. So really 80% of most populations are well. And in so much as we can keep them well and spend more resources on prevention and less on end-stage disease, we move the needle. And of course that takes great personal or individual responsibility. I mean, one of the lessons is you related to or you spoke to is the individuals create the organization. The individuals need to transform if the organization is going to transform, if the collective is going to transform. So each of us bears a responsibility, and to me, the fact that an Aravind exists is proof that it's possible. And many times my colleagues would say, oh yeah, but that was in India. And I'd say, yeah, that was in India. You think we got problems? I mean, what had to be and has to be overcome there is really far more significant than it is here, but with what has been accomplished, it seems like it's not. So there's no question that we have issues and challenges, and they can be an inspiration and a motivation as well as an obstacle.
Ditto, ditto. And I will also add that I think that two things that struck me when I was comparing and talking to people here about the differences in the model things, one of the things that really struck visiting physicians was the transparency of clinical outcomes and how open that information was, even within the system, in pretty unprecedented ways. 200 people within the system would have access to every surgeon's clinical outcomes, and the diligence and the rigor, with which those outcomes were monitored. It doesn't happen here, as I understand it. And the other thing was the thing I talked about earlier was that very important delinking that Aravind did between volumes and compensation. Surgeons are not compensated on the number of surgeries that they do, and that went a long way in keeping the quality up. The third thing, I recently watched Atul Gawande's TED Talk is up now. They put it online a couple days ago. He wrote the Checklist Manifesto, brilliant doctor and a writer. And one of the things he talks about is the crucial necessity now of looking at healthcare providers, not so much in the cowboy model as before, but as pit crews, is what he talked about, You need teams and you need a systems mentality to it, not of kind of people working in silos as it tends to happen here, but an understanding that providing healthcare and keeping people well is a series of interrelated parts. And that dramatically shifts. When you have that mindset, it dramatically shifts the way you structure that care.
Mm-hmm.
Yeah, and I think if you look at the two largest drivers of healthcare costs, the misalignment of the macroeconomics of the industries that comprise healthcare, and then also technology proliferation, it's clear that what Aravind did is essentially radically throw that all to the side and say, as you pointed out, we're going to turn the business model upside down. Mm-hmm. And I think the four of us seem to all be in agreement that that type of change would be very welcomed here. Do we have time for one last question? One more question. And on an inspirational note, maybe for all of you, how do you translate the inspiration you felt in your work abroad into something that you can do on a day-to-day basis? Dr. Stewart?
Are we going to start over here? Well, I certainly changed my professional life based on how I was influenced abroad. And I think a great deal of what holistic health and integrative medicine brings forward in contemporary times in this country initially was couched as ancient wisdom being brought into the contemporary world. But now I think it's becoming increasingly clear that it's not just about ancient wisdom, but it is a model for the future of healthcare. The work that leads us toward prevention, the work that brings the personalized approach, whether that's a high-tech or a high-touch approach, when we can personalize both the high-tech, the definition of when a disease is in its earliest stages, it's going to be easier potentially to manage, and the importance of high touch as part of the healing equation. So I think what looked like it might have been an old model, holism and the interaction of the sacred and the scientific, is becoming a model for future healthcare, not just something that we revisit from the past. And so I'm inspired by that reality and moved by that reality to continue to act in that direction. So I think we're not just honoring the past here, we're moving into the future with the kind of work that's being done at Aravind and at the Institute for Health and Healing and elsewhere.
Such a beautiful answer. I forgot the question. Could you?
The question is, how do you translate the inspiration you felt
yes,
in your...
of course. So for about 3 or 4 years when I was living in India, the first thing I would do when I woke up in the morning was go to Dr. V's office, and I would read with him. And that was how I began my day every day. That was how he began his day every day for, as long as I knew him. And in contemplation and in reading that of greatest value to him. It was a spiritual text called Savitri. And I did this through the time that I was filming him as well for Infinite Vision, the documentary. And that was one of the most powerful experiences for me to, sometimes when you grow up so close to something, you don't really see it, And for me, storytelling around the Aravind epic was a doorway into seeing what had been in front of my eyes all along. And so it was a really powerful experience, and one that I felt was really lifted by grace. And it was something that I didn't eat very much, I didn't sleep very much, and my mother was really worried, and she went and complained to Dr. V about me. And so one morning when I went in to read, he didn't say anything. We finished our reading, and then at the end he looked at me and he said, Pavi, sometimes when we're doing the work that we're meant to do, there are higher forces that will come to work with us. But if you're not quiet inside, they can't stay. So you have to take time to look at the sky. That's what he said. You have to take time to look at the sky, and that was all he said. And, this was a man who knew his place on earth in a deep, fundamental way. And he knew what it meant to be an instrument in the hands of good. And I remember, that evening looking up at the sky and just feeling that sense of humility, that sense of quietness. And that's something I definitely try and remember, because we can so quickly forget. So take time to look at the sky.
Okay. Well, first of all, it's very difficult to follow. Thank you very much. But I would say two things I try to take away on a daily basis pretty much. So my role in my day job, the one that I wear this tie to, is to really work at Sutter Health to try to coordinate care as a chief medical officer and so forth among our various facilities and medical groups in the region. So it's a challenge because our system is so broken that the things that I learned, for example, at Quantichem that you saw about how to address the psychosocial issues, the education, the family, and so forth as part of the whole treatment of a patient is very, very difficult to do in our system. So my work, and I see it as my challenge in my job, is to try to help move us forward and create systems of care that will help get us there. Every day when I get frustrated, I'm thinking that this is really, that's the goal, that's the vision, that's the picture that we're going for, and it kind of helps drive me forward because I know it can happen, I know it can exist, I've seen it, I've worked in it, I understand what it means to do that. And then the question is simply, so how do we do that here? And the other thing I think from the Haiti experience, and I'm kind of looking at Lucy now because, so Haiti was this big disaster. There were all these huge, countries giving billions of dollars here, there, and the other. And at least from what I can see, the things that really made a difference were people that just decided to do something. Somebody just got up and said, we're going to do something. The team, we said, well, we're going to go do something. And I think we've had, in our little piece of the world, it's not the whole country, in our little piece, we're doing something. There was a fellow who came over, you saw those tent cities, who was, I guess he was head of construction company or something, or some guy, I don't even know what his name is, came and brought some equipment and got a bunch of guys together, and they went and they built a whole bunch of homes. Now, it's not millions that they need, and they're just wooden sort of shelters or whatever, but I don't know, he built a few thousand. But that's a guy who just went and did something. So I think the fact that as one person, we often get overwhelmed and say, oh, but I can't. But if you do something, something will happen. And we are empowered, each of us, to do something. I think that's important.
Great, thank you.